a very warm welcome to the third webinar series, Biodiversity Conversations, India's Opportunities and Challenges. These webinars focus on various aspects of the National Mission on Biodiversity and Human Well-being. This webinar series is co-organized by the Office of the Principal Scientific Advisor to the Government of India, the National Biodiversity Authority, and the Biodiversity Collaborative. My name is Prashant. I am a medical doctor and public health researcher at the Institute of Public Health in Bangalore. I work mainly on health policy and systems research, but have a special interest in working with tribal populations in multiple parts of the country. The topic for today's discussion is biodiversity and health, One Health and Zoonoses in vulnerable communities in India. I am delighted that we have a diverse and wonderful set of people who will share their knowledge and experience with us. Before I start introducing the panelists, I have a few announcements to make. Please open your chat box, and all the details that I allude to in my introduction will also be pasted there. We have already received some questions by email, and we welcome additional questions during the webinar as well. So please use the Q&A facility to ask questions to the panelists. Questions that are not answered during the webinar due to shortage of time will be answered via email, and you can also get in touch with the email address that will be pasted into the chat box. We also encourage anonymous questions if that is your preference, but we encourage all of you to include your email ID while sending questions to enable the collaborative to respond to you later in case your question hasn't been dealt with during the webinar. The webinar is being streamed live on Facebook Live, and the link to the Facebook streaming will also be pasted in the chat box. So please feel free to share this link in case you have colleagues who wish to join on that mode. A recording of this webinar will also be updated on YouTube, and the channel link on YouTube where it will be available will also be pasted into the chat box. We gratefully acknowledge the support we have received from the Office of the Principal Scientific Advisor to the Government of India for conducting these series of webinars. During this webinar, the chat facility will be disabled. Please do not use raise your hand function, but we really encourage you to use the Q&A feature that's available in Zoom. And we would very much appreciate an opportunity for there to be an interaction, not only between the panelists, but also between the participants and the various topics that will come up in the panel discussion. So please use the Q&A box to share your comments as well as bring in questions. In case there are any disruptions due to slow internet or power breakdown, we request all of you to be patient, and we will do our best to bring the webinar live as soon as possible. So with those announcements, I will first introduce the format for today's interaction is that there will be initial opening remarks that each of our panelists will make, and the idea is really to benefit from the multiple and rich perspectives that each of today's panelists have with respect to One Health and its effects on vulnerable population. And we have a special focus on adivasi populations as well. So I would like to first introduce Abhi Vanak. Abhi is a senior fellow at the Center for Biodiversity and Conservation in ATRI. He's also a biodiversity collaborative and a fellow of the Wellcome Trust DBT Wellcome Trust DBT India Alliance. Abhi's research areas include animal movement ecology, disease ecology, One Health, savanna ecosystems, and various range of other topics in ecology. His research work has focused on the interactions between species at the interface of human, wildlife, and domestic animals, especially in the savannas and agro ecosystems. Abhi has been doing a lot of One Health based research work and has been championing the cause for intersectoral work in One Health. So I invite Abhi really to set the context for today's interaction by sharing with us the One Health program of the National Mission on Biodiversity. Abhi, over to you.
Thank you, Prashant, and welcome to all the participants of this biodiversity conversations. I'm particularly pleased to introduce the One Health and Zoonoses component of the National Mission for Biodiversity and Human Wellbeing. As one of the lead authors, I've been quite privileged to have interacted with a whole range of different stakeholders in putting this proposal together. And we're happy to see that it's getting a lot of traction and acceptance from the government as well as all the various stakeholders involved. So I'm just going to quickly share my PowerPoint presentation now. Is my screen visible? Okay, great. So the component on biodiversity and health and human health consists of two subcomponents. The one that we are discussing today is One Health and Zoonoses. So this, in a nutshell, is the outline of the two components. So the one that I'm talking about, One Health and Zoonoses, the main aim of this is to operationalize a One Health framework in India to interrupt novel and re-emerging infectious diseases. And it plans to do that through a very extensive program that will examine the relationships between various biodiversity-related parameters, such as land use pattern, changes in land use pattern, biodiversity loss, and the emergence of zoonotic diseases. We also have proposed an extensive, a novel program to map these emerging and re-emerging infectious diseases across India, and it will be operationalized through a network of sentinel surveillance sites. Now I'll present some details on this program to you, but first a little bit of background. If you look at a map of the risk of emerging and re-emerging infectious diseases across the world, so this is the bottom half of the map that you see where some areas are in green, some areas are in red. You see that countries such as India emerge as really hot spots, or rather the hottest of hot spots for the risk of emerging and re-emerging infectious diseases. And this is because of the tight correlation between areas of high biodiversity, which of course India is. India has several biodiversity hotspots, high human population density. Again, we have amongst the highest population densities anywhere in the world, and livestock density. So we tick all those three boxes. And therefore, India, as you can see, along with southern China and some parts, some very small parts of the African continent, emerge as really, really high risk areas for the risk of emerging and re-emerging infectious diseases. Now, most of these diseases are zoonoses or zoonotic in origin, which means that they can emerge from an animal host or an animal reservoir and can infect humans. All of us are now very familiar with this concept because it has been brought home in a way that the world has not seen for almost 100 years. All of us are now dealing with the consequence of the emergence of one such a zoonosis, COVID-19, that is the SARS-CoV-2. Now, for many years, scientists across the world have been championing for a way of looking at the risk of these, or studying the risk of these emerging and re-emerging zoonotic diseases using an integrated approach called the One Health program or the One Health framework. And by definition, the One Health program is a collaborative, multi-sectoral and interdisciplinary and transdisciplinary approach, working at the local, regional, national, and global levels with the goal of achieving optimal health outcomes, recognizing the interconnection between people, animals, plants, and their shared environment. Now, this, of course, is key. Why do we need to do this? Well, for most of these emerging and re-emerging infectious diseases, most of these pathogens, the first signs of trouble can be seen if we monitor illness in animals. Okay, and if you're able to make an intervention before these illnesses emerge in the animals, then the amount of time required to do that is very low. Okay. But if you wait for those illnesses to emerge in humans, then the amount of time versus the number of cases that you see will start rising. And of course, if we wait till there's an outbreak, then it's already too late and we end up suffering the consequences. Okay. Therefore, the One Health mission or the One Health component has an objective to try and implement this national this One Health framework across India. The objective is to develop a national, institutionally, and regionally inclusive strategy to establish an integrated One Health framework for surveillance and control of emerging and re-emerging zoonotic disease risks for human well-being and environmental health. Now, of course, there are many different programs in India that have looked at existing diseases, and there are programs under the various national health programs that have tried to integrate these various components. Here's some examples of these. For example, the Integrated Disease Surveillance Program aims to report diseases in near real time. There's the Viral Hepatitis Surveillance Program, the National Rabies Control Program, and so on. There's also an intersectoral coordination for prevention and control of zoonotic diseases. And all of these are efforts to institutionalize this One Health approach at the national level. Okay, so we want to take this forward as part of this mission to really drive home the point and to develop a framework that is implemented across the country. It contains specific objectives. These are to develop national prioritization of zoonotic pathogens for systematic surveillance. And this prioritization will be done both at national level as well as state levels to identify these potential hotspots if you remember the map that I presented earlier. So we will take those same indicators at the national and at state levels and identify potential hotspots for these emerging pathogens. And then to set up sentinel surveillance sites across India based on these hotspots to develop regional rapid response capacity, to identify and foster capacity for integrated One Health surveillance of some key taxonomic groups across these potential hotspots, and finally to build networks of potential partner institutions and domain experts for running these sentinel surveillance sites. Now, what would such a One Health surveillance program look like? It would basically involve sampling across 3 very different domains. The surveillance program will have to think of, this is classic One Health work where we have to look at human health from an interconnected perspective. Okay, so you have to sample across the wildlife domain, you have to look at livestock health and human health. Okay, so sampling wildlife, especially species which are at high risk interface for zoonotic spillovers. Species that, especially for taxonomic groups such as bats, primates, and rodents. Now, these 3 are also known to harbor most zoonoses, most of the zoonoses that humans are at risk from. There's often an interface involved, whether those zoonoses can transfer directly to humans or whether there's an animal interface required. Usually that animal interface tends to be from our domestic animals. So it's also necessary to monitor livestock health. And eventually, if an outbreak does occur, we have to monitor human health as well. So what we've proposed is setting up a network of these sentinel surveillance sites across India which will be biogeographically represented, which will have state-of-the-art training and research facilities. It will allow integrated sampling across this human-domestic wildlife interface. Okay. What we have mapped here, all those green spots that you see are an example, and these are the zoo facilities available across India, which could serve as potential sentinel surveillance sites. So the capacity could be within these facilities and serve as a good bridge between the animal health, the wildlife health, and the human health. And also most of these are in urban areas, so a larger human footprint is also available for monitoring. The backbone of this program will be through a grants program, which will enable team science. So we do not, the main thing is that teams from these different disciplines have to come together to conduct the surveillance at each of these sites. So it's not just people from the livestock sector or from the wildlife sector all doing their own thing. No, we have to have these different teams coming together with the same protocols and sampling in a coordinated fashion across each of these areas. There'll also be training programs, there'll be grants for training programs, and finally we'll build critical infrastructure that's really, really required in each of these areas, especially higher biosafety capacity labs at each of these areas. So we really develop the overall health infrastructure in the country. So once implemented, we hope that this will lead to a national action plan for integrated One Health surveillance. As I mentioned before, we'll identify arid hotspots, and we'll have these partners, institutions, and experts identified, as well as the sentinel surveillance sites and standardized protocols for integrated One Health surveillance. Now, another highlight of this program will be real-time reporting and integration of these surveillance databases into a database that is accessible by planners from district to state to national levels. And we hope to do this, so the policy implications of this will be that we'll be able to mobilize a strategic network of more than 300 plus institutions that are currently undertaking some form of research. It will provide the evidence needed to operationalize a One Health platform and develop a strong programmatic structure for these multi-sectoral efforts. And eventually, the impacts outcomes of this program will be to strengthen infrastructure and capacity across these sectors. It will also serve, each of these sentinel surveillance sites will serve as a single focal point for all these pathogens, especially of zoonotic origin. More importantly, we'll also, by mapping across these different institutions, this program proposes to have to implement a One Health orientation of existing sectoral policies across the board. That will allow us to have coordinated plans and guidelines for each of the sectoral partners at local, state, and national levels, and it will provide templates for setting up multiple national One Health research centers. Thank you, Prashant. And with that, I'll end my talk and hand it over back to you.
Thank you, Abhi. And that seems both ambitious and challenging, given that One Health kind of research requires new kinds of collaborations and new kinds of opening up of fairly sectoral kind of thinking, not only in researchers, but also in governments and all other sectors. So maybe then this is a great link to our next panelist, Dr. Syed Abbas, who is a postdoctoral researcher at the Institute of Development Studies in Sussex, United Kingdom, and an adjunct faculty at the Public Health Foundation of India. Welcome, Dr. Syed. Dr. Syed is a public health researcher whose main area of expertise is around politics of multi-sector One Health collaborations around zoonotic diseases. He is studying how technical experts and program managers employ scientific evidence for decision making in the very dynamic and changing social and political environments that many of these outbreaks characterize. So Dr. Syed, over to you. Maybe brief opening remarks on the health system and national level perspective on One Health.
Thanks very much, Prashant, for the introduction. And let me try to share my screen with you. Is it all right? Yeah, excellent. Thanks. So again, I'm really glad to be here and to be able to speaking with such a large and a diverse group of people who are interested in the topics of biodiversity and how it relates to One Health. So I started as a public health researcher, as Prashant said, but I moved on to looking at multi-sectoral One Health collaborations. So pushing on the boundaries of health systems definition per se. So I couldn't resist taking some liberties with the topic assigned to me, and I've tried to take a broader look at the vulnerabilities in zoonosis, both in terms of the communities it affects, as well as some of the zoonoses themselves and how neglected they are. So I realized that there's not much time that we have, so I'll try to be very quick and speak on three different points. One would be the neglect of zoonoses themselves and the communities it affects. The second is going to be what reason and how it manifests, identify potential drivers of this neglect, and maybe see if there are any points to think about and how it can be remedy this situation. So very quickly, so when we think of zoonoses, obviously the kind of diseases that come to our mind are like SARS, coronavirus, like Ebola, like even bird flu or rabies. But when we speak to but there's a host of other zoonotic diseases which are very endemic and affects people hugely, even though we don't talk about it. So I'm really glad that Abhi showed the global maps that he did, which talked about increased risk of zoonosis in different settings. And if you just superimpose those maps about biodiversity hotspots and disease risk hotspots, and try to find out, try to see the density of poor livestock keepers, for example, you'll find that it is those areas where lots of these changes are taking place, lots of human animal interaction are taking place. At the same time, places like India, which have animals and people, their carers, living close together in conditions of poverty, in conditions of poor hygiene, and that makes a very potent combination of factors which might lead to increased risk for disease emergence. And you have to ask that, if things are so bad, it's only are only the risk for emerging diseases increasing, or is it also the case that other zoonotic diseases which are already there in this population, diseases like brucellosis, like anthrax, like bovine tuberculosis, like leptospirosis, so the host of other conditions as well. And what we often find is that these exotic diseases like pandemic prone diseases, epidemic prone diseases, they tend to grab the headlines about the and gain more visibility at the expense of the endemic diseases, which are much more common, like brucellosis or bovine tuberculosis. And you'll find that there's this gap in discourse. The global level, people like to talk about these big scary diseases, whereas if you ask the people who are really affected, and if you go and try to find out what's happening there, you find the endemic disease to be much more common, even though they might not be diagnosed as frequently as they should be doing. So what is the reason potentially? I propose that it's, and some other authors also talk about it, that it's basically a self-perpetuating cycle of neglect. Many of these diseases have non-specific symptoms and they're difficult to diagnose, especially in communities which don't have good health facilities and which are hard to reach. So you have low disease numbers being reported, and this means the diseases are less visible, and this also And if the diseases are less visible, it leads to decrease and reduced policy interest. And that means that, no recent bodies funding research there. There's not enough data being generated, which leads to further neglect of the same diseases. So I think it's a vicious circle that we need to break. And I'm really glad about initiatives like the one Abhi talked about in the biodiversity initiative. So I think it's really good to have more initiatives on these fronts. Having talked about the disease neglect themselves, let's try to examine what potential drivers of neglect might exist. So one could be in global health. As I mentioned, certain diseases tend to get prioritized over others. There's also a culture where, we want to get technical fixes, scientific solutions, even though practical local solutions might be available for the same reasons. So there's a gap between high sciences versus low sciences, local knowledges versus, global knowledges, to put it crudely. The other factor I think is also contributing is that oftentimes science and scientists are put on a pedestal. So what happens is the kind of critique that scientific decisions or public health interventions need to be put to, it's not given to them. Science and scientific decision making is ascribed to science, and it is depoliticized. So that is something. For example, go to leptospirosis. Huge number of antibiotics is being distributed every year, in endemic areas, even though there's really, really patchy evidence for it. And same is the case with other conditions as well. So we need to find out what is the science informing it, and what are the rationales informing such decisions. The last thing I talk about, last point I can think is also important, is about institutional capacities. Those areas, those state governments, health is a state subject. So those states which have large institutional capacities, which have more scientists, more public health researchers, more epidemiologists, they tend to have slightly better evidence-informed decisions. Even though that is a bit questionable, but they tend to make decisions which are slightly more grounded in science than others. So we've had this very quick look at the potential different ways in which neglect manifests itself. What can we do about it? One thing, one important point to recognize about zoonoses is, given the fact that zoonotic diseases don't occupy limelight generally, unlike the current situation, so zoonosis discussions tend to take place in closed spaces. There are not many people who are interested in zoonoses. There are not many people who have the expertise to be able to talk about zoonoses. So it becomes a bit of a closed space. So we need to open those up in some ways. We definitely need to invest in lab capacities, surveillance systems, health service provision, without which you can't actually understand what is going on where. But at the same time, we need to also open up the science, make sure the scientific research we do is grounded in social needs. We need to increase public engagement and participation in science. For example, the way we are conducting this webinar, so that scientists can interact with the general public and vice versa. And both perspectives can inform each other. And it's only then that we'll be able to debate and critique the decisions that get made on our behalf much more openly and rationally. So that's my point, and very good to be here, and happy to answer questions afterwards if required.
Thank you, Dr. Abbas. And I think you make a very powerful point about when you contrast the on one hand the need for more research, with also the need for involving communities, with the need for involving managers, implementers in areas where the infrastructure for these do not exist. And that links very well with all the next three speakers, in fact. So thank you for that. So I next invite Dr. Tanya Seshadri, who brings in the community health and community engagement perspective. Dr. Tanya is the director of the Tribal Health Resource Center, the Vivekananda Girijana Kalyana Kendra in BR Hills in southern Karnataka, Chamarajanagar district. She is a medical doctor by training with a specialization in community health and with experience with working with tribal communities in southern and northeast India. And in the last decade, her work has focused on implementation research on maternal health and community health workers working in tribal communities, And as you see, these are the communities are literally at the first line in terms of exposure and risk to many of these illnesses. In the past year, she has begun working with One Health Consortium that works on Casanova forest disease in Karnataka and Kerala. Dr. Tanya, maybe your opening remarks, and I request to keep it to 5 minutes so that we have sufficient time to take on the questions that have already started coming in. Dr. Tanya?
Thanks, Prashant, and thanks to the Biodiversity Collaborative and the National Biodiversity Mission for inviting me to speak. Now, I was asked to talk a bit about the potential for community engagement in forested areas. I don't have a PPT, but I thought I'd make just a few points to you. Typically, when we talk about community engagement in One Health or in Zoonoses, we're often talking from a perspective of, trying to bring in a rapid response, have a quick impact strategy that has a quick effect, look for early detection of triggers, specific disease surveillance. In fact, a lot of what Abhi did mention in the first talk. And when we identify something, then it's about coming together, outbreak management, mobile teams, paratrooping in literally into these forest spaces. And the idea of community engagement is often limited to just gathering local support and local cooperation so that all these activities happen smoothly and effectively. Now, coming to One Health, the first question that I'd like to start is yes, I'm asking questions and human health. But often we see from the approaches so far, including Casanova forest disease, which I work with, is that it doesn't appear to be well balanced, at least in the way it is implemented. In human health, also the key strategy, like even what we see in COVID, is about changing human behavior. Of course, there is vaccination, but again, depending on the type of disease, the vaccine and its side effects, etc., can be a big factor. But the main focus is on changing human behavior. And when we talk about different types of zoonoses in One Health, like Dr. Syed mentioned, One Health approaches across the different parts of Asia have been found to be quite successful as a management strategy. It's been very successful in bringing together different researchers from different departments, different sectors, etc. But let's just pause and talk about also the tribal people across India very significantly from region to region. So much of what I'm about those living in Scheduled 5 southern states of India, which are not scheduled, and it may not be, it's very far away from the truth of those living on islands or in Schedule 6. So please bear with me on that. When we talk about the tribal people in these areas, their behavior has already been significantly impacted. Can eat what they can eat, what kind of jobs can they do, how they must live, and even in many conversations, we often tend to pitch tribal people against wildlife as if we are having a conversation on tiger versus people or landscapes versus people. So it is in this conversation that we're trying to bring in the idea of One Health, which is about we all are equally valuable. So that's just something I wanted to talk about. But, I work with the Solega people in Chamarajanagar district. And one of the first conversations as a doctor that I had here was asking the question on how do you see your health or what is important? And a response that I got right in 2012 when I started working was that our health is intertwined, entangled with the health of our forests and the health of the animals within it. No one of us can live without the other. And that was a start of a conversation where they were also talking about why the people are important to forests, not just about wildlife, right? And so when you look at indigenous worldviews across the globe, actually, whether you talk about Aboriginal or Torres Strait Islanders or First Nations in Canada, we find this common thread of that the indigenous worldview, really precedes the One Health framework in recognizing the importance of bringing the environment animal health and human health together. So let's pause and so I request you to pause and recognize that the struggle that technicians have in coming together and working together and implementing strategies are because of the worldviews, the frameworks that we have decided to work in. And One Health may seem, well, it's about 20, 30 years old, right? So it may seem relatively new to us, but actually for many of the communities, their worldview has been like this for beyond zoonosis and beyond a particular disease. In fact, when you read about conversations on forest rights and land rights, you see that people talk about the link of their spiritual link, their physical health and mental that they live in. But when it comes to our systems, we tend to often look at them as people living in remote areas, vulnerable, socially vulnerable, not just biologically, but also we look at how do we deliver services to the last mile. So we often see them as the toughest people to reach. And that's why a lot of our strategies are also developed in that way. I found a very interesting, there is a very interesting work called the Kampala Manifesto, and I invite all of you to read it. I found a paper on it in PLOS NTDs by Dickman et al., where after Ebola, they brought together what they called communities. These were health workers, leaders, traditional healers, journalists, in fact, from the community who came together in conversations of how can we prepare ourselves if this were to happen again, right? And a few of the key points that emerged during the workshops is what I want to share with you. The first important thing they spoke about was changing the narrative, of moving away from a don't have or a victim narrative to a more powerful action narrative of, instead of saying we don't have money, don't have labs, move towards talking about how can we come together, what kind of leadership is needed for this to move ahead. Moving away from a telling or a training and a capacity building, a one-way strategy, to more listening and understanding how do many of the communities understand these diseases or these the relationships of the diseases with forests, because often the socio-cultural factors are the reasons why they are resilient, they resist a lot of the strategies that are implemented. And also not just go through formal structures of leadership, but also recognize that there are informal leaders. For instance, in Karnataka, if you want to engage with the tribal people, going through the panchayat will actually prove to be a disadvantage for you, right? Most importantly, to shift power to the people from the system. And now this could lead to a discrepancy in priority setting. You may want to have a conversation on food security, but they may be wanting to talk about income generation. So, but this was found to be an important conversation to have. And the last thing I want to talk about here was a very beautiful sentence where they talk about realizing the beauty of the Ebola legacy. And that was what they called community-based One Health. They saw Ebola as having happened as a unique opportunity to build and strengthen health and local health systems according to local needs and wishes. And it is with this point that I want to end my talk, that even when you look at One Health in Canada, they found, and I think we can also find, that unlike our other public health approaches, One Health is keeping different worldviews together. That is the thing about One Health, the umbrella. As a boundary object, you can have different definitions coexisting, different conflicts of interest, apparent conflicts of interest, also coexistent. And we can move to a model where we can have open conversations and cross-cultural dialogues even on these conditions, but also their prevention or management strategies. But to go there, we first need to recognize the experience that tribal communities and forest regulations. We need to recognize their history with health services, with governments and government regulations, and also in some instances with research, and they view research and the importance of it. And only then can we move ahead in building relationships so that we can, achieve outbreak down indicators, but also we can build the long-term goal of building a resilient local health system according to their needs, and that is culturally sensitive. So with that, I end my talk. Thank you so much for letting me share my thoughts.
Thank you. Thank
Over
you,
to you, Prashant.
Dr. Tanya. Thank you. And that's really a very interesting connect that emerges from looking at One Health as a research heavy and a biomedicine heavy agenda towards shifting it much more towards a community engaged and cross-cultural dialogue. And I think that's a very powerful point you make about those challenges. This links beautifully to Sushila, to Ms. Sushila K, who will be our next speaker. Sushila is a social worker from Udupi district in Karnataka. She's completed a BA in journalism and a master's in social work from Mangalore University. She is passionate about health and development of Adivasi communities in southern and coastal Karnataka and is currently an honorary associate at the Institute of Public Health in Bangalore. Sushila is very special because she is also among all of the other accomplishments. She is also belongs to the Koraga community, which is one of the PVTG communities in Karnataka. And she has also worked with several social movements of multiple Adivasi communities in southern and coastal Karnataka. Sushila will be speaking to us in Kannada, and I request, as arranged previously, Tanya to kindly put a translation in English of what she will say. Sushila ಅವರೇ, ವೆಲ್ಕಮ್. ನಿಮ್ಮಿಂದ ಮುಂಚೆ ನಾವು ಮಾತಾಡ್ದಂಗೆ ಆದಿವಾಸಿ ಸಮುದಾಯಗಳ ಮೇಲೆ ಈ ರೀತಿಯ ಒಂದು ಒನ್ ಹೆಲ್ತ್ ಮತ್ತೆ ಝೂನೋಟಿಕ್ ಡಿಸೀಸ್ ಒತ್ತಡ ಮತ್ತೆ ಇದರ ಪರಿಣಾಮಗಳು ಹೇಗೆ, ಮತ್ತೆ ಅದ್ರ ಬಗ್ಗೆ ನಿಮ್ಮ ದೃಷ್ಟಿಕೋನವನ್ನ ನೀವು ಶೇರ್ ಮಾಡ್ಕೋತೀರಾ?
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಮೊದಲಾಗಿ ಮೇಡಮ್ ಎಲ್ಲ ವಿಷಯ ಅವರು ನಿಯರ್ ಬೈ ಅವರು ಒಂದು ಪರ್ಟಿಕ್ಯುಲರ್ ಆಗಿ ಸೋಲಿಗ ಕಮ್ಯುನಿಟಿ ಒಟ್ಟಿಗೆ ಕೆಲಸ ಮಾಡಿದ್ರು, ಎಲ್ಲ ವಿಷಯಗಳನ್ನು ಶೇರ್ ಮಾಡಿದ್ದಾರೆ. ಆದ್ರೂ ನಾನು ಒಟ್ಟಾಗಿ ನಾನು ಕೂಡ ಒಂದು ಆದಿವಾಸಿ ಸಮುದಾಯದವಳಾಗಿದ್ದು ಒಟ್ಟು 4-5 ನಮ್ಮ ಆದಿವಾಸಿ ಸಮುದಾಯದೊಟ್ಟಿಗೆ ಕೆಲಸ ಮಾಡಿದ್ದೇನೆ. ಒಟ್ಟಾರೆ ಹೇಳುದಿದ್ರೆ ನಮ್ಮ ಆದಿವಾಸಿ ಸಮುದಾಯವೇ ಇಡೀ ಜೀವ ವೈವಿಧ್ಯ ಮತ್ತು ಆರೋಗ್ಯ. ಈ ಜೀವ ವೈವಿಧ್ಯ ಮತ್ತು ಆರೋಗ್ಯ ಇದು ಇಡೀ ನಮ್ಮ ಆದಿವಾಸಿ ಜೀವ ವೈವಿಧ್ಯವೇ ಇಡೀ ನಮ್ಮ ಆರೋಗ್ಯದ ಮೇಲೆ ಆಗ್ಬಹುದು, ಸಾಮಾಜಿಕವಾಗಿರ್ಬೋದು, ಆರ್ಥಿಕವಾಗಿರ್ಬೋದು, ಸಾಂಸ್ಕೃತಿಕವಾಗಿರ್ಬೋದು, ಇದೆಲ್ಲದೂ ಕೂಡ ಜೀವ ವೈವಿಧ್ಯತೆಯ ಮೇಲೆ ನಿಂತಿರುವಂತದ್ದು. ಬಟ್ ಈ ವಿಷಯದ ಮೇಲೆ ನಾನೊಂದು 3 ವಿಷಯಗಳನ್ನು ಶೇರ್ ಮಾಡ್ಲಿಕ್ಕೆ ನನ್ನ ದೃಷ್ಟಿಕೋನದಲ್ಲಿ ಇಷ್ಟಪಡ್ತೀನಿ. ಮೊದಲನೇದಾಗಿ ನಮ್ಮ ಆದಿವಾಸಿ ಪ್ರದೇಶಗಳಲ್ಲಿ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಹೇಗಿದೆ, ಈ ಹಿಂದೆ ಹೇಗಿತ್ತು, ಇತ್ತೀಚಿನ ಹಿಂದಿನ ಪರಿಸ್ಥಿತಿಯಲ್ಲಿ ನಾವು ಕಾಡಿನಂಚಲ್ಲಿ ಇರೋದು ಯಾವತ್ತು ನಮ್ಗೆ ರೀಚ್ ಆಗದೇ ಆಗಿರೋದಂತೆ. ಆದ್ರೆ ಇತ್ತೀಚಿನ ಕಾಲಘಟ್ಟದಲ್ಲಿ ಈಗಿನ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ನಿಜವಾಗ್ಲೂ ತುಂಬಾ ಅದರ ಪರಿಣಾಮ ನಮ್ಮ ಮೇಲೆ ಬೀರಿದೆ ಅಂತ ಹೇಳ್ಬೋದು. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ನಾವೊಂದು ಕಾಡಂಚಿನಲ್ಲಿ ಇರುವುದರಿಂದ ನಮ್ಮ ಆರೋಗ್ಯ, ನಮ್ಮ ಪ್ರಾಥಮಿಕ, ನಮ್ಮ ಸಮುದಾಯಕ್ಕೆ, ಇಡೀ ಆದಿವಾಸಿ ಸಮುದಾಯಕ್ಕೆನೆ ಒಂದು ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ, ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಮೇಡಮ್ ಹೇಳಿದಾಗೆ ತಲುಪ್ತಾ ಇಲ್ಲ. ಅದರಲ್ಲಿಯೂ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಇದ್ರೂ ಕೂಡ ನಮ್ಮಲ್ಲಿ ಅದಕ್ಕೆ ಸಿಬ್ಬಂದಿಗಳ ಕೊರತೆ ಇರ್ಬೋದು. ಅಲ್ಲಿಯೂ ಕೂಡ ಒಂದು ಆರೋಗ್ಯ ಸ್ನೇಹಿಯಾಗಿ, ಒಬ್ಬ ಸಮುದಾಯದ ಆರೋಗ್ಯ ಸ್ನೇಹಿಯಾಗಿ ಅಲ್ಲಿ ಯಾವುದೇ ಕೂಡ ಸೌಲಭ್ಯಗಳ ಕೊರತೆ ಇರುವುದರಿಂದ ನಮ್ಮವರು ಅದನ್ನು ಪ್ರಯೋಜನ ಪಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯತೆ ಇಲ್ಲ. ಹಾಗಾಗಿ ಆ ಆರೋಗ್ಯಕ್ಕೆ ನಮ್ಗೆ ಒಂದು ಜೀವ ವೈವಿಧ್ಯತೆಯಲ್ಲಿ ನಾವೇನು ಒಟ್ಟಾಗಿ ಬದುಕುತ್ತಿರುವುದರಿಂದ ಆ ಆರೋಗ್ಯಕ್ಕೆ ಪೂರಕವಾಗಿ ಹೇಳುದಿದ್ರೆ ನಮ್ಮಲ್ಲಿ ನಮ್ಮ ಇಡೀ ಆರೋಗ್ಯ ಸಮುದಾಯಕ್ಕೆ ಹೇಗೆಲ್ಲ ಆರೋಗ್ಯಕ್ಕೆ ಪರಿಣಾಮ ಬೀರುತ್ತೆ. ಒಂದು ಮೂಲಭೂತ ಸೌಕರ್ಯಗಳು, ನಮಗೆ ಒಂದು ಒಳ್ಳೆ ಮನೆ ಆಗಿರ್ಬೋದು, ಅದಕ್ಕೆ ಒಂದು ಒಳ್ಳೆ ವ್ಯವಸ್ಥೆ, ಗುಣಮಟ್ಟದ ನೀರಿನ ವ್ಯವಸ್ಥೆ ಇರ್ಬೋದು, ಅಥವಾ ಸ್ನಾನದ ಗೃಹ ಇರ್ಬೋದು, ಶೌಚಾಲಯ ಇರ್ಬೋದು, ಅಥವಾ ನಮ್ಮ ಕಾಡಿನಲ್ಲಿಗೆ ಬರುವಂತ ಒಂದು ರಸ್ತೆ ಕೂಡ ಇರ್ಬೋದು. ಅದು ಎಲ್ಲದೂ ಕೂಡ ಇವತ್ತು ನಮ್ಮ ಆರೋಗ್ಯದ ಮೇಲೆ ತುಂಬಾ ಪರಿಣಾಮ ಬೀರ್ತಾ ಇದೆ. ಇದು ಒಂದು ವಿಷಯ. ಎರಡನೇದಾಗಿ ನಾನು ಹೇಳ್ತಾ ಇರೋದು, ನಮ್ಮ ಇಡೀ ಸಮುದಾಯದ ಬದುಕು ನಿಂತಿರುವಂತದ್ದೇ ಅರಣ್ಯ ಹಕ್ಕಿನ ಮೇಲೆ. ಇವತ್ತು ನಾವು ಏನು ಅಂತ ನಮ್ಮ ಆರೋಗ್ಯ ಇರ್ಬೋದು, ನಮ್ಮ ಆರ್ಥಿಕ ವ್ಯವಸ್ಥೆ ಕೂಡ ನಿಂತಿರುವುದೇ ನಮ್ಮ ಫಾರೆಸ್ಟ್ ರೈಟ್ ಮೇಲೆ. ಈಗ ಒಂದು ವೇಳೆ ನಾವು ಫಾರೆಸ್ಟ್, ಈಗ ನಾವು ಮುಂಚೆ ನಾವು ಅರಣ್ಯದಲ್ಲಿ ಬದುಕುತ್ತಿರುವ, ನಮ್ಗೆ ಅಲ್ಲಿ ಒಳ್ಳೆವಾದ ಶುದ್ಧವಾದ ಗಾಳಿ ಇರ್ಬೋದು, ವಾತಾವರಣ ಇರ್ಬೋದು, ಫುಡ್ ಇರ್ಬೋದು, ಎಲ್ಲದೂ ಕೂಡ ನಾವು ಅಲ್ಲಿ ನಮ್ಮ ಅಲ್ಲಿಯೇ ನಾವು ಒಂದು ಆರ್ಗಾನಿಕ್ ಆಗಿ ಪಡ್ಕೊಳ್ತಿದ್ವಿ. ಬಟ್ ಇತ್ತೀಚಿನ ಕಾಡಿನಿಂದ ಹೊರಗೆ ಬಂದ ನಂತರ ನಾವು ಅದು ಎಲ್ಲದೂ ಕೂಡ ಕೊಂಡುಕೊಳ್ಳುವಂತಹ ಪರಿಸ್ಥಿತಿಗೆ ಬಂದು ಇವತ್ತು ನಾವೆಲ್ಲರೂ ನಮ್ಮ ಸಾಂಸ್ಕೃತಿಕ ಬದುಕಿರ್ಬಹುದು, ಆರ್ಥಿಕ ಬದುಕಿರ್ಬಹುದು, ಆರೋಗ್ಯ ಇರ್ಬೋದು, ಎಲ್ಲದೂ ಕೂಡ ಕಾಡಿನಿಂದ ಹೊರಗೆ ಬಂದ ನಂತರ ನಮ್ಗೆ ತುಂಬಾ ಪರಿಣಾಮ ಬೀರಿದೆ. ಇದು ನಾವು ಫಾರೆಸ್ಟ್ ನಿಂದ ಹೇಗೆ ಹೊರಗಡೆ ಬಂದಿವೆವೋ ಅದಾದ ನಂತರ ನಮ್ಮ ಈ ಬದುಕಿಗೆ ನಮ್ಗೆ ತುಂಬಾ ಅರಣ್ಯ ಹಕ್ಕು ನಮ್ಮ ಅರಣ್ಯದಿಂದ ಏನು ಹೊರಗಡೆ ಬಂದಿದ್ವಿ, ನಮಗೆ ನಮ್ಮ ಬದುಕು, ನಮ್ಮ ಸುಸ್ಥಿರ ಜೀವನ ಬದುಕಿಗೆ ತುಂಬಾ ಅಡೆತಡೆ ಆಗಿದೆ. ಹಾಗಾಗಿ ಇದು ಒಂದು ಎರಡನೇ ವಿಷಯ. ಮೂರನೇ ವಿಷಯ, ನಾವು ನಮ್ಮಲ್ಲಿಯೇ ಒಂದು ನಂಬಿಕೆ, ಆರೋಗ್ಯ ಅಂತ ಹೇಳಿದ್ರೆ ನಮ್ಮಲ್ಲಿ ಸಾಂಪ್ರದಾಯಿಕವಾಗಿ ನಮ್ಮಲ್ಲಿ ಆದಿವಾಸಿಗಳ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ ಇತ್ತು. ಬಟ್ ಎಲ್ಲಾ ವಿಷಯಗಳು ಚಿಕ್ಕ ಒಂದು ಆರೋಗ್ಯದ ವಿಷಯಕ್ಕೆ ನಮ್ಮಲ್ಲಿ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ ಇತ್ತು. ಬಟ್ ಇತ್ತೀಚಿನ ಕಾಲಘಟ್ಟದಲ್ಲಿ ಅದು ಎಲ್ಲದೂ ಕೂಡ ಈ ಸಾಂಸ್ಕೃತಿಕ ಅಥವಾ ನಮ್ಮ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿಗೆ ಕಾಡಿನಲ್ಲಿ ಅದಕ್ಕೆ ಪೂರಕವಾದ ಒಂದು ಮೂಲಭೂತ ಸಲಕರಣೆಗಳು ಸಿಗದ ಕಾರಣ ನಮ್ಮ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ ದಿನೇ ನಶಿಸಿ ಹೋಗ್ತಾ ಇದೆ. ಈಗಿನ ಯುವ ಜನತೆಗೂ ಕೂಡ ಅದನ್ನು ಫಾರ್ವರ್ಡ್ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗ್ತಾ ಇಲ್ಲ. ಬಟ್ ಅದು ಈ ಫಾರೆಸ್ಟ್ ನಿಂದ ಹೇಗೆ ಹೊರಗೆ ಬಂದಿವೆ ಅದರ ನಂತರ ಈ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ ಅನ್ನುವಂಥದ್ದು ನಶಿಸಿ ಹೋಗ್ತಾ ಇದೆ. ಅದಕ್ಕೆ ಪೂರಕವಾಗಿ ಹೇಳುದಿದ್ರೆ ನಮ್ಮ ಈಗಿನ ಆಧುನಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ನಮ್ಮ ಆದಿವಾಸಿ ಸಮುದಾಯಕ್ಕೆ ಆರೋಗ್ಯ ಸ್ನೇಹಿಯಾಗಿ ಇದೆಯಾ? ಅದರಲ್ಲಿ ನಮ್ಮನ್ನು ಅದಕ್ಕೆ ಪೂರಕವಾಗಿ ನಮ್ಮಲ್ಲಿ ಈಗಿನ ಆಧುನಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆಗೆ ನಮ್ಮಲ್ಲಿ ಅದಕ್ಕೆ ವಿಶ್ವಾಸತೆ ಇದೆಯಾ, ನಂಬಿಕೆ ಇದೆಯಾ? ಅದೆಲ್ಲದೂ ಕೂಡ ಇದಕ್ಕೆ ನಮ್ಮ ಆರೋಗ್ಯದ ಮೇಲೆ ಪರಿಣಾಮ ಬೀರಿದೆ ಅಂತಾನೆ ನಾನು ಹೇಳ್ಬೋದು. ಈ ಮೂರು ವಿಷಯಗಳಿಗೆ ಪೂರಕವಾಗಿ ನಂದು ಮೂರು ಬೇಡಿಕೆಗಳು ಅಂತ ಬೇಡಿಕೆ ಅಥವಾ ಹೇಳುದಿದ್ರೆ, ಮೊದಲನೇದಾಗಿ ನಮ್ಮ ಸಮುದಾಯಕ್ಕೆ ಆರೋಗ್ಯಕರವಾಗಿ ಇರ್ಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ನಮ್ಮಲ್ಲಿ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಅದೊಂದು ಗುಣಮಟ್ಟದ ಸರ್ಕಾರಿ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ. ಯಾಕಂದ್ರೆ ನಮ್ಮಲ್ಲಿ ಖಾಸಗಿ ವ್ಯವಸ್ಥೆ ಕೊಟ್ರೆ ನಮ್ಮ ಹತ್ರ ಇನ್ಕಮ್ ಇಲ್ಲ. ಅರಣ್ಯದಿಂದ ಹೊರಗೆ ಬಂದ ನಂತರ ನಾವು ಮೈಗ್ರೇಟ್ ಆಗ್ತಾ ಇದ್ವಿ, ಬಟ್ ಅಲ್ಲಿ ಆದಾಯದ ಕೊರತೆ ಇದೆ. ಹಾಗಾಗಿ ಆ ಇನ್ಕಮ್ ಇಲ್ಲದಿರುವುದ ಕಾರಣ ನಮ್ಮ ಸರ್ಕಾರಿ ವ್ಯವಸ್ಥೆಯಲ್ಲಿ, ನಮ್ಮದೇ ಒಂದು ವ್ಯವಸ್ಥೆಯಲ್ಲಿ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆಯನ್ನು ಸಮುದಾಯಕ್ಕೆ ಹತ್ತಿರವಿರುವ ಯಾಕಂದ್ರೆ ನಾವು ಸಿಟಿಗೆ ಹೋಗ್ಲಿಕ್ಕೆ ಆಗಲ್ಲ, ಯಾಕಂದ್ರೆ ನಾವು ಕಾಡಿನಂಚಿಲಿರುವುದು. ನಮ್ಮ ಸಮುದಾಯಕ್ಕೆ ಹತ್ತಿರವಾಗಿರುವ ಕಾರಣ ಅಲ್ಲಿ ಒಂದು ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಅದೊಂದು ಗುಣಮಟ್ಟದಿರ್ಬೇಕು. ಮತ್ತೆ ಅದೊಂದು ಅಲ್ಲಿನ ಸಿಬ್ಬಂದಿಗಳು ಅವರ ನಡತೆ ಇರ್ಬೋದು, ಅವರ ಸ್ನೇಹ, ಅದು ಸಮುದಾಯಕ್ಕೆ ಒಂದು ಸ್ನೇಹಿಯಾಗಿರ್ಬೇಕು. ಇಂಥ ವ್ಯವಸ್ಥೆಯನ್ನು ಸರ್ಕಾರ ನಮ್ಗೆ ಒಂದು ಫೆಸಿಲಿಟೇಟ್ ಮಾಡಬೇಕು ಅನ್ನೋದು ನನ್ನ ಒಂದು ಬೇಡಿಕೆ. ಎರಡನೇದು, ಇದು ಎಲ್ಲದಕ್ಕೂ ಪೂರಕವಾಗಿ ಅರಣ್ಯ ಹಕ್ಕಲ್ಲಿ ಕೂಡ ಸಮುದಾಯದ ಹಕ್ಕು ನಮಗೆ ನಿಜವಾಗ್ಲೂ ತುಂಬಾ ಬೇಡಿಕೆ ಇರುವ ವಿಷಯ. ಯಾಕಂದ್ರೆ ಅರಣ್ಯಕ್ಕೆ ಸಿಕ್ಕಿದ ಕೂಡಲೇ ಅಲ್ಲಿ ಒಳಗೆ ಅಲ್ಲಿ ಬರಬೇಡಿ, ಇಲ್ಲಿ ಬರಬೇಡಿ, ಆಕ್ಟ್ ಸರ್ಕಾರದ ಏನು ವನ್ಯಜೀವಿ ಆಕ್ಟ್ ಕಾಯ್ದೆ ಪ್ರಕಾರ ನಾವು ಒಳಗೆ ಹೋಗುವಾಗಿಲ್ಲ. ಬಟ್ ಸಮುದಾಯದ ಹಕ್ಕು ಸಿಕ್ಕಿದ್ರೆ ನಮಗೆ ಅಲ್ಲಿನ ಎಲ್ಲಾ ವ್ಯವಸ್ಥೆಗಳನ್ನು ಅಳವಡಿಸಿಕೊಳ್ಳಲಿಕ್ಕೆ ಒಂದು ವ್ಯವಸ್ಥೆ. ಇಲ್ಲಿ ಫಾರೆಸ್ಟ್ ರೈಟ್ ನಲ್ಲಿ ನಮ್ಗೆ ನಮ್ಮದೇ ಆದ ಆಹಾರ ಪದ್ಧತಿಯನ್ನು ಕೊಂಡ್ಕೊಳ್ಬಹುದು, ಒಳ್ಳೆ ಜೀವನ ನಡೆಸಬಹುದು. ಅದಕ್ಕಿಂತ ಹೆಚ್ಚಾಗಿ ಇನ್ಕಮ್ ಅದಕ್ಕೆ, ಯಾಕೆ ಮೈಗ್ರೇಟ್ ಆದ ನಂತರ ನಮ್ಮಲ್ಲಿ ಈಗ ಒಳ್ಳೇದು ಕೆಟ್ಟದು ಎಲ್ಲಾ ವಿಷಯಗಳು ನಮ್ಮ ಜನತೆ ಕಲಿತಿದೆ. ಬಟ್ ಎಲ್ಲಿ ನಾವು ಫಾರೆಸ್ಟ್ ಒಳಗಡೆ ಇದ್ದೀವೋ ಅಲ್ಲಿ ನಮ್ಮ ಇನ್ಕಮ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ, ನಮ್ಮ ಸಾಂಸ್ಕೃತಿಕ ಬದುಕು ಚೆನ್ನಾಗಾಗತ್ತೆ, ಆರೋಗ್ಯ ಚೆನ್ನಾಗಾಗತ್ತೆ. ಇದು ಎಲ್ಲದೂ ಕೂಡ ನಮ್ಗೆ ಇಂಪಾರ್ಟೆಂಟ್ ಆಗಿ ಈ ಆರೋಗ್ಯಕ್ಕೆ ಪೂರಕವಾಗಿ ಜೀವ ವೈವಿಧ್ಯತೆಯಲ್ಲಿ ಅರಣ್ಯದ ಹಕ್ಕು ತುಂಬಾ ಪ್ರಾಮುಖ್ಯತೆ ಇದೆ. ಮೂರನೆಯದಾಗಿ ನಾನು ಏನು ಹೇಳಿದೆ, ನಂಬಿಕೆ. ನಮ್ಮ ಸಮುದಾಯದಲ್ಲಿ ಯಾರೇ ಏನೇ ಕೆಲಸ ಮಾಡುದಿದ್ರು ಆರೋಗ್ಯದ ವಿಷಯದಲ್ಲಿ ಕೆಲಸ ಮಾಡುದು ನಂಬಿಕೆ ಬೇಕು. ಅದು ನಮ್ಮ ಆಧುನಿಕ ವ್ಯವಸ್ಥೆ ಏನು ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಇದೆ, ಬಟ್ ನಮ್ಮ ಈಗಿನ ಏನು ನಶಿಸಿ ಹೋಗ್ತಾ ಇದೆ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ, ಅದು ಮತ್ತೆ ನಮ್ಮ ಆಧುನಿಕ ವ್ಯವಸ್ಥೆ ಎರಡು ಒಟ್ಟಿಗೆ ಕೊಂಡೋಗ್ಲಿಕ್ಕೆ ಸಾಧ್ಯತೆ ಇದೆಯಾ ಸರ್ಕಾರದೊಟ್ಟಿಗೆ? ಯಾಕಂದ್ರೆ ಅದು ಕೂಡ ನಮ್ಮ ಬದುಕು ಒಂದು ಭಾಗ. ಬಟ್ ಅದನ್ನು ಉಳಿಸಿಕೊಂಡು ನಮ್ಮ ಆಧುನಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆಯಲ್ಲಿ ಒಟ್ಟಿಗೆ ಕೊಂಡು ಹೋಗ್ಲಿಕ್ಕೆ ಸಾಧ್ಯತೆ ಇದೆಯಾ ಎನ್ನುವುದು ನನ್ನ ಆಶಯ. ಇದು ನನ್ನ ಸಮುದಾಯದ ಒಟ್ಟಿಗೆ ನಾನು ಬದುಕುತ್ತಿರುವ ಈ ಒಂದು ಇದರೊಟ್ಟಿಗೆ ನನ್ನ ದೃಷ್ಟಿಕೋನ ಅಂತೆ. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
ತುಂಬಾ ಧನ್ಯವಾದಗಳು ಸುಶೀಲಾ. ನಿಮ್ಮ 3 ಪಾಯಿಂಟ್ಸ್ ನ ತುಂಬಾ ಸಂಕ್ಷಿಪ್ತವಾಗಿ ತುಂಬಾ ಚೆನ್ನಾಗಿ ವಿವರಿಸಿದ್ರಿ. ತುಂಬಾ ಧನ್ಯವಾದಗಳು. Sushila's, just to reiterate, a quick translation of Sushila's points has been pasted in the chat window, and I hope people who do not understand Kannada can access the translation. But I thought that was very beautifully illustrated about the need to take on very challenging things like trust in government health services and improving trust in science and modern services in order to be able to connect and engage with many communities. But also Sushila's points about fixing very fundamental amenities in many of these populations: electricity, housing, piped water supply, road connectivity. All of these are very fundamental in order to protect health as well as mitigate the vulnerabilities that these populations face. Tumba dhanyavadagalu Sushila. I'm aware that we are exceeding the time allocated, but I didn't want to interrupt given the rich perspectives that are emerging. So please continue to ask your questions on the Q&A, and to the extent possible we'll answer them here. Otherwise we will get back on email. Our final speaker is a very important champion, I would say, who is at the front lines right now of multiple zoonotic diseases. Dr. Kiran is the Deputy Director at the Virus Diagnostics Laboratory in Shivamogga in Karnataka, and has been at the forefront of acting on zoonoses for a long time. He has already been dealing with the Casanur forest disease outbreak multiple seasons, multiple years. He works with the Department of Health and Family Welfare Services, Government of Karnataka, and he's in charge of the KFD disease management and surveillance. He's also supervising the Casanur forest disease immunization activities and has been actively involved also in research. So he's developed long-term partnerships with researchers on One Health-like projects. Dr. Kiran, welcome, and could you make your opening remarks on what is the kind of strengthening of health services in many of these rural and forested areas in order to better integrate the One Health framework? You are muted, Dr. Kiran. Can you unmute yourself, please?
No, am I audible now?
Yeah, you're audible. Please go ahead.
Thank you, Dr. Prashant, for the rich introduction, and good evening to all the participants. And first of all, my topic is the strengthening of health service that's there in the government of Karnataka or wherever. What I would like to say in the beginning is we already have a lot of things that are in place, but only thing we need to tweak a little bit of our strategies and focus and the way we look at the things. The few points I would like to make here is, one is the availability, that is the availability of health personnel in the field. We already have our health personnel like ASHA, accredited social health worker at the grassroots level. There are like something like one ASHA for each 200 to 250 households. That's covering around 1,000 population. This ASHA, she's basically from the community itself, as we all know. And she brings in a lot of local wisdom to our health system. And we need to take her view also in formulating our strategies in preventing zoonotic disease. Because all these days we are using ASHA, the expertise and the services of ASHA mainly in the respect of maternal and child health. Only in certain areas like surveillance of larva for dengue control and other things, we are using their services. But if we train our ASHAs, if we orient them properly, and if we get a good perspective about what's changing in their immediate surrounding, like is there any monkey dying in their immediate vicinity, if we get that information from ASHA, and if we make her aware of these important facts that she need to notice, then it's going to help us a lot in preventing or controlling these or strengthening our health system. And at the same time, ASHA can collaborate with other departments also, like veterinary department. If she's collecting or she's giving us some information about the tick density in her place, that also will give a lot of information about the priority or preventive activity we can carry upon, we can carry. And the next in line comes our health workers. Actually, there are quite a lot of health workers are there in the system. But the saddest part is the most difficult to reach area. In those areas only we are having this the shortage of these health workers. Now, one more thing, we have so many health programs nowadays that most of these our health workers are spending more time in the sub centers and the primary health centers rather than the field. Most of the time they'll be dealing with the data and the reports they need to send to the taluka level or district level or something like that. So if you kind of de-stress them or take away this responsibility from them and have additional data operators at the primary health centers level so that he can look after all the data related works are reporting, it's kind of brings them to the field and gives a very good perspective of what's happening, actually happening in the field and what we can do to prevent many diseases. And then our government of Karnataka is trying to bring in the MLHPs, mid-level health providers. They are kind of science graduates trained a bit in the medical knowledge and how to treat disease in a syndromic through a syndromic approach. If we engage them properly, they can act like a very good link between the community and at the sub-center level to the primary health center and then to the at the taluka level. So that needs to be prioritized with the personal side. And regarding this health facilities, as Ms. Sushila was telling, we already have a lot of health facilities, but still our experience tells that the most difficult to reach area, they need to walk or travel at least 5 kilometers to reach the nearest health facility, like a sub-center or a primary health center. So that we need to take care of, or at least we should provide them with a good mobile vans. It's going to help them a lot, I think. And one more thing I would like to suggest here is we should not only cater to the human health. We should actually, from the veterinary department also, there is one mobile health unit that is visiting these villages. But if we coordinate our strategy in such a way that both the people from the veterinary department and both the people from the health department are visiting the same village at the same day, actually there's going to be very good exchange of the information also. What we see in the field is there will be so many brucellosis cases identified by veterinary department, but that go unnoticed. It doesn't come to the notice of health department. So we'll be missing so many brucellosis cases in the field. And same with the rabies also. People actually don't know what are the symptoms of rabies in the cattle population. So there will be some active rabies cases in the cattle, and it can get accidentally transmitted to the humans also. But we'll be missing those cases. So if we have this collaborative operation at the field level, that's going to help us a lot. And then we come to the accessibility. The accessibility,
I think we seem to have are experiencing connection difficulties with Dr. Kiran. I'll just wait for a few more seconds and.
hello?
Kiran? Yeah.
Yeah, am I audible now?
After accessibility, we lost you.
The accessibility part. Accessibility should be something like a person should be able to access health facility from a health personnel around the clock or at the time which is most beneficial to him. Our beneficiaries are actually the daily wages workers who work in the field, who work in the plantation, and they are very busy during the daytime, or during the time when our health facilities or health personnel are at work. Something like these people go to the field at 8 o'clock in the morning, we open our facility at 9 o'clock in the mornings. They'll be engaged in the field and they won't come to our health facilities to seek or to take care of their health, because they'll be losing one day of their wages if they come to the hospital. So what we should do, or what our strategy should be, we should be working at those hours, like in the afternoon, when these our target population are free, or they can come and visit our health facilities. And the next thing I would like to stress upon is quality. Even though most of the time we provide health to personnel, health facilities are there, the one thing we miss in the rural or the most difficult areas is a good diagnostic or laboratory facilities. Most of the times, what I observed is, even if the facility has a small one cell counter machine with one engaging a dedicated laboratory lab technologies, it helps us a lot in identifying so many diseases, or at least screen so many diseases at the village level itself. That quality, that laboratory backup is very much needed, and this can be achieved even through this the mobile health van I was speaking earlier. And even the veterinary department also has a similar the kind of the national program also, and at the same time they have this mobile health unit that keeps visiting and keeps testing so many things. And if you have this multi-sectoral or exchange of information to gather at the PSC at the village level, that will strengthen our system on the ground level a lot, I think. And the next part is the transportation. All these health facilities, maybe they are situated very near to our the village people or our targeted beneficiaries. But once they are treated at PSC, and if the need arises for them to get them transported to the secondary healthcare centers or tertiary healthcare centers, situation changes dramatically. Because even if you refer them to the higher centers, they won't go by themselves. Either they go to the nearby another private doctor who is not as much qualified as our doctors in primary health centers. They spend a very crucial period in that time, and only when the disease gets complicated, then only they come to our secondary or tertiary care centers. If you have a system wherein a person who is diagnosed or who cannot be treated at the PSC level, and if you have a dedicated transportation system where a patient can be accompanied by ASHA, just like what we are doing in the maternal healthcare, where a pregnant woman is transported along with ASHA to the secondary care center or tertiary care center. If you accompany an ASHA worker for transporting a zoonotic disease patient from a primary health center to secondary care center, through the engagement of local community, like engaging local NGOs, or making some local transportation facility, things will change dramatically, I think. And the next thing is, even once they go to the higher centers, there's always this issue of bearing the bills, medical bills. As we see, that's a big issue nowadays. People are actually scared to go to a tertiary care center. If we have a proper insurance scheme, like we have ABARK, Ayushman Bharat Arogya Karnataka, but the saddest part is the person who should be getting this facility, he doesn't have that card, or he doesn't have that information also. So instead of having this ABARK covering only specific surgical conditions, if we have this region-specific, disease-specific insurance coverage for under ABARK, that will help a lot, I think. And the most important part is the coordination. As I was stressing throughout, there's always a requirement for good coordination at ground level, because we see this coordination meeting occurring only at the taluka level or district level, but we don't see any the coordination meeting between health department, agriculture department, or horticulture department, or forest at the grassroots level, village level, where the real action is taking place. And the most important part is the IEC, information, education, and communication. That's the most neglected part, I think, we need to take care of. Why? Because the most of the time, these people, if we give the example of PFD, as that Tanya was telling, through our health department, we try to read them. We'll ask them to take the vaccine. We have been doing this since many, many years. But I don't know, is it because some lacuna in our imparting this IEC, or because of some other things, we are not able to convince even today to accept this vaccination in a full way. So for that, what I suggest is, if we have a multi-sectoral approach, or approaching through this multi-sectoral approach, approaching a group of people like small NGOs, self-help groups, if in that way, if we engage them, instead of along with engaging them at the village level or hamlet level, or even at the family level, if we engage them at self-help group level, it is going to have a much bigger impact, and it will help in strengthening our health system and also preventing and taking care of a lot of zoonotic diseases. Thank you.
Thank you very much, Dr. Kiran. That's really a very interesting linked but a broad spectrum of perspectives, beginning with Dr. Abhi's view of how the mission looks at things, and going from there towards the research, the national level picture, and the implementer and community picture. With permission from the organizers, we extend till 5:20, just so that we can do some justice to the very, very interesting questions that are coming up. Unfortunately, we will not be able to take up all of them, and whichever questions are not taken up today, we will attempt to answer it over email, wherever emails are provided. But I thought I can bunch together some themes and do one quick round across the panel for to to allow you an opportunity also to respond to each other. So maybe we can begin with Dr. Abbas. Dr. Abbas, coming back to you, one is to hear what you think about the other perspectives that came from Tanya, Dr. Kiran, and Sushila. And second is also what is very clear is that One Health is and One Health related collaboration is not only research and science framework. It seems to be much more embedded in practice, in implementers like Dr. Kiran, in leaders in the government, as well as community representatives. And I particularly point to one question that is coming where people talk of also how communities may not have the same agenda of wanting One Health. They may have their own interests in terms of, like Sushila said, forest rights, amenities, etc. Could you share maybe your reflection on how you see this tension and what you think could be potential ways?
Sure, thanks, Prashant. I completely agree, and that's been one of the major focus of my research. My current research is different actors have their own perspectives, their own agendas, and it is important to recognize that when we talk about a certain understanding of One Health, we are privileging some understandings or point of views over others. So which understandings get prioritized and which don't? I think we need to be cognizant of this to be able to make sense of what's being discussed. I was a part of a research prioritization exercise back in 2011, and we realized in this from this exercise was that we interviewed program managers, policymakers, and also some civil society people. And we realized that while the policymakers and the experts, they spoke the most, and they had some pretty good options. The practitioners and the program managers, they spoke the least, but the few times they spoke, their research options ranked the highest. So it doesn't matter who has the facility to be able to engage in discourse or not. What is important is that we take their perspectives on board. So yes, I think it's important we recognize the different agendas coming into the mix, and that's the way forward, I guess.
And just to probe you a bit further on that, do you see, do you see potentially, and perhaps Abhi, if you have any thoughts on this as well, what could be sort of institutional frameworks of allowing such collaboration? And here I particularly point to one question where one of the participants, Anika, asks about, right now, for example, in health, you have multiple programs: leprosy elimination program, vector-borne disease control program, you have a program for rabies, you have a national health mission, and now you have a mission in biodiversity. So how do you see the challenges and how do you see many of these coming together, especially given that Dr. Kiran was pointing out that on ground, you need even more coming together of these departments at district level, taluka level, and at city administration level? Maybe first Dr. Abbas and then Dr. Abhi, if you also have any thoughts on this.
Yeah, I'll be very quick. I think both formal as well as informal elements to collaborations are both important. You can't have formal One Health collaborations without the informal understandings, networks, and relationships in place. And you can't only talk about informal collaborations if there's no formal institutional backup to be able to support interventions or practices on the ground. So I think it's important that when we talk about One Health, we realize that we need to take both formal as well as informal together.
Dr. Abhi, before you come in, this is a very interesting point on informal collaborations, because Dr. Kiran's work in Shimoga also shows that currently the informal is the predominant one. So he is able to achieve One Health collaboration through existing social networks that someone like him has at the district level. So I think that's a very important point you make, and I'll bring in Dr. Kiran on that later. Dr. Abhi, anything on this?
Thanks. I think, okay, so there's so many aspects to this. So one of the first things that you mentioned, there's already several programs that are running by the government, and as part of the precursor to the mission, what we're actually doing is mapping many of these different networks that exist, so many of these different verticals that exist, we'll actually be publishing. There'll be a special issue of EPW that will publish some of this work on the mission, where we'll where this actor network will actually be analyzed. And what we are proposing, in fact, is that there be One Health coordination cells embedded within each of these, so that they sort of talk to each other, or at least there's a broader understanding of what is happening. Because right now, in many cases, there's, the right hand doesn't seem to know what the left hand is doing, or there's duplication, or sometimes there's even action at cross purposes with each other. One quick example I'll give is, many people don't think of this as a One Health problem, but the action that was taken on the locust swarms, for example, that just came across in Rajasthan and Gujarat, the action was to aerially spray with chemical pesticides. Is the cure going to be worse than the disease? In this case, that's something also that we need to, is the cost, the downstream cost of that, in terms of human health, animal health, environmental health, ecological health, going to be far worse than any crop damage that the locusts themselves could have caused. Those kinds of examples come to mind, where basically I think this intersectoral part of it needs to be at every node of these different ministries, and we really need to be thinking about them talking to each other, and that has to percolate down to the lowest possible level. So the state level, the district level, the sub-district level, wherever is the lowest unit. That's, as Dr. Kiran himself, as you just talked about, the formal informal networks. How do you formalize some mechanism is in place so that this thinking is brought in? I think broadly the framework needs to be in place, so that, and it's the beauty of this framework is that it allows for a huge to be able to be integrated into one common thing and localized. So that's the only thing that I want to mention.
Thank you. Then maybe let me now move to Dr. Kiran. Dr. Kiran, you must have heard this, and I know that you have earlier spoken about how in the KFT outbreak management, in the Casanur forest disease outbreak management, which Shimoga district has many years of experience in doing. How did you, could you share very briefly, how did you bring about a sort of a One Health, although there is no framework currently asking for One Health collaboration, you have earlier triggered informal networks and collaborations between departments. From that, can you share any lessons as to what we should think of in future for districts and cities to achieve more intersectoral coordination? What could be good ways forward to formalize such intersectoral One Health collaborations?
One thing, for this collaboration to take place, we need to have somebody who is supervising or coordinating between all these departments. Mainly the system where we are working, it's all the power that matters. If you have a person who is the district head, who has this inbuilt knowledge, or who is the kind of properly coordinating or helping out, smoothen out the rough edges of all the department and making them sit together and work, that will help us a lot. Fortunately, the most of the time, as you have discussed last year, we had one deputy commissioner at the district level was kind of facilitating all those things, and it became very easy for us to move ahead. And the next thing we should, at all the level, I think we should engage our elected representatives. I think most of the time we try to keep away them from all our preventive activities, thinking that they are kind of a hindrance. But if we engage them properly, and if we make them get convinced of the motives and the outcome that we can expect out of this, I think it will help a lot in achieving this multi-sectoral coordination. And it takes kind of it applies to all the diseases, I think, even the leptospirosis, even the KFD, even the dengue, where not just the veterinary forest, and even dengue, the setup we are talking about is in the urban area. It will help us a lot. And only thing, we have to take them and make them understand our intention and the outcome that we can expect out of this. I think that will help.
Thank you. And I think the underscoring of the need to engage with elected representatives, whether you like it or not, because it has to be that way. I think that point you make is very vital. This is not a technical discussion among biologists or doctors. This is a wider discussion. Thank you, Dr. Kiran. Next, maybe I'll move to Dr. Tanya. Dr. Tanya, at least two of the questions talk about this idea of how do you engage communities in instances where the interests of the community may not match very much with the agenda currently under discussion. If they have, and I'll later invite Sushila as well to dwell upon this. Are there any ways of community engagement or existing ways, either in the National Health Mission or otherwise, which can be leveraged and strengthened and improved for improving community engagement on One Health and Zoonoses? Any thoughts on that? Dr. Tanya is not audible. Maybe quickly to move on then to Sushila. Sushila ಅವರೇ ಒಂದು ಪ್ರಶ್ನೆ ಬಂದಿರೋದು ಇದರಲ್ಲಿ ನೀವು ಆದಿವಾಸಿ ಸಮುದಾಯಗಳ ಬಗ್ಗೆ
yeah, you know,
yeah, sorry, go ahead, Tanya.
Can you hear me? Hello?
You're audible now. Maybe there appears to be a huge delay. So Tanya, can I request you to please type your message in the chat box. And while I bring in Sushila, Sushila ಅವರೇ ಈಗ ಸಮಯ ತುಂಬಾ ಇಲ್ಲ, ಸ್ವಲ್ಪ ಬ್ರೀಫ್ ಆಗಿ ನಿಮ್ಮ ಪ್ರಕಾರ ಆದಿವಾಸಿ ಸಮುದಾಯಗಳ ಜೊತೆ ಈ ರೀತಿಯ ಒಂದು ಒನ್ ಹೆಲ್ತ್ ಮತ್ತೆ ಈ ಝೂನೋಟಿಕ್ ಡಿಸೀಸಸ್, ಸಾಂಕ್ರಾಮಿಕ ಕಾಯಿಲೆಗಳ ಬಗ್ಗೆ ನಿವಾರಣೆ ಬಗ್ಗೆ ನಾವು ಕೆಲಸ ಮಾಡಬೇಕಾದ್ರೆ ನಿಮ್ಮ ಕಡೆಯಿಂದ ಯಾವ ಸಜೆಷನ್ಸ್ ಕೊಡ್ತೀರಾ? ಹೇಗೆ ಸಮುದಾಯ ಸಂಘಟನೆ ಮತ್ತೆ ಸಮುದಾಯ ಸಹಭಾಗಿತ್ವದೊಡನೆ ಇದನ್ನ ಮಾಡೋದು? ನಿಮ್ಮ ಪ್ರಕಾರ ಏನು ಸಜೆಷನ್ಸ್ ಇದೆ ಇದಕ್ಕೆ? ಆದ್ರೆ ಈ ರೀತಿ ಒಂದು ಪ್ರಶ್ನೆನೂ ಬಂದಿದೆ.
ಒಂದು ನಾನು ಈಗ ಸಾಂಕ್ರಾಮಿಕ ಕಾಯಿಲೆ ಬಗ್ಗೆ ಒಂದು ನಮ್ಮ ಸಮುದಾಯದ, ನಾನು ಮೊದಲೇ ಹೇಳಿದಾಗೆ ಮೂರನೇ ಪಾಯಿಂಟ್ ನಂಬಿಕೆಯ ವಿಷಯಗಳು, ಅವರನ್ನು ಒಂದು ವಿಶ್ವಾಸಾರ್ಹತೆಗೆ ತೆಗೆದುಕೊಂಡು, ಬಟ್ ಇಲ್ಲಿ ಸಾಂಕ್ರಾಮಿಕ ಕಾಯಿಲೆ ಒಂದೇ ಅಲ್ಲ. ಈಗ ಇವತ್ತಿನ ವಿಷಯ ಅದು ಸಾಂಕ್ರಾಮಿಕ ಕಾಯಿಲೆ ಬಂದಿರ್ಬೋದು, ಬಟ್ ತುಂಬಾ ಹೆಲ್ತ್ ಇಶ್ಯೂಗಳು ನಮ್ಮ ಸಮುದಾಯದಲ್ಲಿ ಇದೆ. ಬಟ್ ನಾವು ಹೇಳಿದಾಗೆ ಅದು ಪ್ರಾಥಮಿಕವಾಗಿ ಅದು ಏನು ಅಂತ ಪರೀಕ್ಷೆ ಮಾಡದೇನೆ ಒಂದು ಡಿಸಿಷನ್ಗೆ ಬಂದ್ಬಿಡ್ತಾರೆ. ಅದು ಏನು ಟ್ರೈನಿಂಗ್ ಮಾಡೋದು ಅದು ಇದೆಲ್ಲ. ಬಟ್ ಯಾವ ಸಮುದಾಯಕ್ಕೆ ಅದು ಸಾಂಕ್ರಾಮಿಕ ಕಾಯಿಲೆನ ಬೇಸಿಕ್ ಅದೊಂದು ಪಾಯಿಂಟ್ ಔಟ್ ಮಾಡ್ಕೊಂಡು ಸಮುದಾಯದ ಒಟ್ಟೊಟ್ಟಿಗೆ ಇದು ಕೆಲಸ ಆಗ್ಬೇಕು ಅನ್ನೋದು ನನ್ನ ಇದು.
Okay, thank you. So I think Sushila brings back the discussion about improving trust between communities and services. And I think that's also something Dr. Kiran pointed out. And this is not a problem only of tribal communities. We are seeing this idea of vaccine denialism in the United States heavily. We are seeing it in urban society. So this idea of wider scientific engagement with communities with respect to modern medicine and approaches, I think is an important challenge. Tanya, did you, before I move towards closure, did you have any final thoughts? I see that you're back. No, I think she's struggling with a very poor connection. So I think I'm aware that we have opened up multiple threads in a very rich conversation, and it would be very difficult for me to achieve any kind of a summary. I think I will let the speakers and the perspectives speak for themselves. They have said a lot. And I'm also aware that there are a lot of open questions. I can count 26 questions here. We will make a best effort to answer them. Wherever email addresses are provided, we will get back to you with the responses. With this, I would really like to thank all our speakers, and some of our speakers especially are at the front lines of working against COVID as well, and many of you are also have also been other important responsibilities, and thank you very much for joining. And I would very much like to thank our participants for a very rich conversation that has carried on over chat. So the next webinar in this series is entitled Biodiversity and Ecosystem Services, Understanding, Restoring and Conserving Biodiversity to Ensure our Future. This will be live on Friday, 25th September, and some of these links will also be pasted on the chat box. There's a further one on 3rd October on biodiversity and health, valorizing medicinal plants and traditional knowledge for the 21st century on Saturday. And another one on 9th October on enhancing people's participation in the People's Biodiversity Register framework. So with this, I really thank all the speakers, and we thank all of you for attending the webinar. And for further information, please write to us via email on contact@biodiversitycollaborative.org, and those links will come up on the chat box. And we once again acknowledge the support we have received from the Office of the Principal Scientific Advisor to the Government of India for conducting these webinars. And I request everyone to follow the Biodiversity Collaborative on various social media handles. We look forward to receiving you at the next webinar. Thank you all of you.